Welcome back. And if you are doing your OBGYN rotation and if you're about to take an exam, this video is for you. We will cover another 30 questions. This is a part 3 video where we'll cover 120 EOR, PANCE, and PANRE exam style questions with OBGYN. Everything will be covered, every single topic will be covered, and we will cover why the wrong answers are wrong. So let's begin. A 28-year-old woman presents with a lower abdominal pain, fever, cervical motion tenderness on a pelvic exam. What is the most likely diagnosis? Ectopic pregnancy, PID, endometriosis, or ovarian torsion? And the answer is PID. And the clue in this is the patient presented with fever, lower abdominal pain, and that chandelier sign. In ectopic pregnancy, there will be pain, but usually there's no fever. Endometriosis causes chronic cyclic pain, but there is no acute infection. And a torsion causes sudden, severe pain, and it's often unilateral. So when it comes to pelvic inflammatory disease, think of a hot pelvis that screams on touch. Think pelvic inflammatory disease. A 28-year-old woman complains of foul-smelling green discharge and vulvar itching. On microscopy, motile flagellated organisms are seen. What is the treatment? Metronidazole for patient and partner, fluconazole, clindamycin, or azithromycin? And the answer is metronidazole for a patient and a partner. This is a classical presentation of Trichomonas vaginalis, which requires treating both partners. Fluconazole is made for the yeast, clindamycin for BV, and azithromycin is for chlamydia. So the giveaway in this question would be that tricky green flagellated. And you're going to be thinking metro. Every time I think of metronidazole, I think of metro station, and I think of two people being in there, and it's foul-smelling green discharge, making me think of Trichomonas vaginalis. So here's a little picture that can help you remember everything you need to know about Trichomonas. Uh, the magician is holding two flags meaning for 2 grams. That is the dose for treatment. 2 flags, 2 grams, zap the infection. Also, there's a sign saying no alcohol on metro. So the patient should not be taking alcohol while taking metronidazole. And you just remember being in a metro station, magician is holding 2 flags for 2 grams of metronidazole, and there's no alcohol. Question number 3. A 33-year-old woman presents with infertility and severe dysmenorrhea. She notes that intercourse has become increasingly painful. Physical exam reveals fixed retroverted uterus and tenderness along the uterosacral ligament. Ultrasound shows homogeneous cyst lesion on a left ovary. What is the most likely diagnosis? Endometriosis, adenomyosis, PID, or ovarian cystadenoma? This is a classical presentation of endometriosis. Patient is going to have that cyclic pelvic pain, dyspareunia, infertility, and a chocolate cyst indicates endometriosis. Adenomyosis will cause uniform uterine enlargement. PID causes acute pain and cervical motion tenderness, and cystadenoma is usually painless. So if you see fixed, painful, infertility, you should be thinking about endometrial tissue misplacement. This is a good time to tell you guys if you are in OBGYN rotation, I just published a book on 120 exam style questions just like this, and we cover every topic from the blueprint. This book will save you so much time studying. It will prepare you like you would not believe, and it's on Amazon, so go ahead and check it out. It will save you a tremendous amount of time so you can spend it during your rotation or with your loved ones. So let's continue. I will leave the link in the description below. A 29-year-old woman presents with irregular menses and difficulty conceiving. She reports increased facial hair and acne over the past year. Her BMI is 32. Labs reveal elevated LH and FSH ratio and increased testosterone level. Pelvic ultrasound shows multiple peripheral follicles on both ovaries. What is the most likely diagnosis? POC, Cushing's, congenital adrenal hyperplasia, or ovarian coma. This is a classical presentation of polycystic ovarian syndrome. So patient is going to have hyperandrogenism, obesity, and chronic anovulation, which will define PCOS. Cushing will cause striae and a moon feces, and congenital adrenal hyperplasia will present earlier with virilization. Etiocoma produces estrogen, not androgen. So heavy patient, hairy, and hormones are high, think of PCOS. I hope you guys find these questions helpful, and I would appreciate if you leave a comment down below letting me know what you think about these types of videos, if they're helpful or not, or what can I change. A 56-year-old postmenopausal woman presents with a painless vaginal bleeding. She has a history of obesity and hypertension, but denies hormone therapy. Transvaginal ultrasound shows a endometrial stripe of 8 millimeters. What is the next best step in management? A tip that I can give you about exams is always pay attention on the last sentence. Are they asking what's the next step or what is the next best step? Because those two can be very, very different. Endometrial biopsy, hysterosalpinogram, pap smear, or pelvic MRI. Well, in this presentation, she's gonna need a biopsy because any postmenopausal bleeding warrants biopsy to rule out carcinoma. This is a 56-year-old lady with painless vaginal bleeding. So hysterosalpinogram is for infertility, PEP detects cervical, not uterine or cancer, and MRI is a secondary imaging. It's not initial. So bleeding postmenopause, biopsy first. Do not wait, just order biopsy. A 38-year-old G2P1 presents 36 weeks gestation with sudden, severe abdominal pain and dark vaginal bleeding. Her blood pressure is 90/58. Her pulse is 120. Fetal monitoring shows late decelerations. The uterus is rigid and tender. What is the most likely diagnosis? Placenta previa, uterine rupture, placenta abruption, and a vasa previa. This is a classical presentation of placental abruption because she presents with painful bleeding, painful being a key word in that sentence to differentiate placenta previa from placenta abruption. Tender uterus and a fetal distress suggests abruption. Previa is painless. Rupture occurs with the prior C-section scar, and vasa previa is fetal blood loss, not maternal. So painful and dark, think abruption. A 30-year-old woman presents with abnormal uterine bleeding between cycles. Her pap smear is normal. Transvaginal ultrasound reveals an echogenic mass within a uterus cavity with a single feeding vessel. What is the most likely diagnosis? Endometrial polyp, submucosal fibroid, adenomyosis, adenometrial carcinoma. This will be the presentation of endometrial polyp because you're going to see that there's a focal lesion with a single feeding vessel causing intermenstrual bleeding. That single feeding vessel was a giveaway in this question. Fibroids distort urine, counter, and are multiple. Adenomyosis causes diffuse uterine enlargement, and cancer causes postmenopausal bleeding and thickened lining. So one vessel, one growth, endometrial polyp. A 26-year-old woman with a recent IUD placement presents with fever, pelvic pain, and a mucopurulent cervical discharge. On exam, there is a cervical motion tenderness and adnexal tenderness bilaterally. What is the most likely diagnosis? PID, endometriosis, tubovarian abscess, or ovarian torsion? Well, this is another spin on pelvic inflammatory disease, but the giveaway is going to be the same. She has fever, she has that chandelier sign, and she presents with a lower abdominal pain. Endometriosis is chronic and afebrile. Abscess is a complication, not initial presentation of the PID, and the torsion causes unilateral pain. So when the cervix screams and fever beams, it's PID. When cervix screams, a lot of pain, and fever beams, think of PID. A 20-year-old nulliparous woman presents with a cyclic pelvic pain that begins 1 to 2 days before menstruation and resolves afterwards. NSAIDs provide minimal relief. Pelvic ultrasound is normal. What is the next best step in management? Start combined OCPs, diagnostic laparoscopy, endometrial biopsy, or pelvic MRI. And she will need a laparoscopy. So normal imaging with cyclic pain refractory to medication it's possible endometriosis. So she needs laparoscopy to confirm that. OCP may be treating her symptoms, but there's no diagnosis from OCPs. Biopsies for bleeding abnormalities and MRIs are rarely added diagnostic value in the early presentation. So pain that hides, laparoscopy decides. Pain that hides, laparoscopy decides. So she had that cyclic pelvic pain, resolves afterwards, NSAIDs are minimal relief, ultrasound is normal, think laparoscopy. A 34-year-old woman in her trimester presents with a sudden, painless vaginal bleeding. She has no abdominal pain and her uterus is soft and non-tender. Fetal heart rate tracing is reassuring. What is the most likely diagnosis? Placental abruption, placenta previa, vasa previa, or uterine rupture? And the answer is this is a classical presentation of placenta previa, where a patient will present with painless, bright red bleeding with a soft uterus. Placenta is covering the os. Abruption is painful. Vasa previa causes fetal distress, and the rupture causes hemodynamic instability. So one of the questions you ask yourself in any presentation is her bleeding painful or painless. That's the best way to differentiate abruption from previa, and in this case is painless, leading us to placenta previa. A 29-year-old null-Paris woman presents with a 3-month history of irregular, heavy menstrual bleeding and intermenstrual spotting. She reports new onset pelvic pressure and a sensation of fullness, worse at the end of the menses. On pelvic exam, the uterus feels enlarged but smooth and slightly mobile. Transvaginal ultrasound shows a 4 cm, well circumscribed intramural mass distorting the uterine contour. What is the most likely diagnosis? Fibroid, adenomyosis, endometrial polyp, or endometrial carcinoma? So this is a classical presentation of the fibroids. They're going to be discrete, well circumscribed intramural mass with uterine enlargement and heavy bleeding, which is a classical of fibroids. Adenomyosis is diffuse with a boggy tender uterus, not the discrete mass. Polyp is intracavitary and smaller, often causing intramenstrual bleeding only, and the cancer usually occurs postmenopausal and shows heterogeneous endometrium. So a single smooth mass that bulks the uterus should make you think about fibroids. A 34-year-old woman reports months of progressive galactorrhea and amenorrhea. She is not pregnant. Physical exam reveals bitemporal hemianopsia on confrontational testing. Serum prolactin is markedly elevated. MRI shows 1.2 cm cellular mass confined to the pituitary. What is the best initial management to restore menses and reduce the tumor size? Transphenoidal surgery, dopamine agonist therapy, radiation therapy, or observation only? Well, this is a classical presentation of prolactinomas. The mass is greater than 1 cm, so she will need a dopamine agonist therapy, such as cabergoline. Responds well to dopamine agonists, which shrinks the tumor and restores the gonadal function. First line for microadenomas. Microadenomas, they're going to need dopamine agonists. Surgery is reserved for dopamine agonist failure, intolerability, or apoplexy. Radiation is for refractory or aggressive tumors, and observation risk progression of the tumor and enlargement and a further vision loss. So high prolactin plus vision field loss, you should start thinking about starting dopamine agonists before cutting into that patient. A 17-year-old female presents with a sudden onset severe unilateral lower abdominal pain, nausea, and vomiting. She is febrile and tachycardic. On exam, there is palpable tender adnexal mass and guarding. Pregnancy test is negative. Color Doppler ultrasound reveals an enlarged ovary with an absent arterial flow. What is the most urgent next step? Start oral analgesics and observe. IV fluids and urgent surgical detortion. Antibiotic and hospitalized for PID, percutaneous aspiration of ovarian cyst. The answer is that she needs a surgeon to look at it, urgent IV fluid, and a surgical detorsion, laparoscopy, since this is a classical presentation of ovarian torsion, given that there's an absent blood flow, and this makes it a surgical emergency requiring prompt detorsion of the salvage to salvage the ovary. Observation delay necessary reperfusion, PID does not cause absent flow, and aspiration won't restore the blood flow. So twisted ovary, no flow, take it to the OR now. So in her presentation on a Doppler ultrasound, you see there's an absent flow. She's febrile, so she needs to go to OR to help save that ovary. A 40-year-old perimenopausal woman complains of hot flashes, night sweats, and recent insomnia. She has a history of estrogen receptor positive breast cancer treated 3 years ago with lumpectomy and tamoxifen. She wants she wants a relief from vasomotor symptoms. What is the safest evidence-based option for her symptoms? Systemic estrogen therapy, paroxetine or venlafaxine for vasomotor symptom control, combined estrogen progestin therapy, or hormone replacement with conjunctive equine estrogen and progestin. So she needs an SSRI or SNRI for vasomotor symptom control. For women with a history of estrogen receptor positive breast cancer, non-hormonal therapy like SSRI or SNRI are preferred for vasomotor symptoms. All three other answers are systemic hormone therapy and is generally contraindicated in those with recent estrogen sensitive breast cancer. So, in a question stem, if you have perimenopausal woman with a history of the breast cancer, use non hormonal pills for her hot flashes. A 34-year-old woman in her third trimester presents with sudden painless vaginal bleeding. Painless vaginal bleeding. She has no abdominal pain and her uterus is soft and non-tender. Fetal heart rate tracing is reassuring. What is the most likely diagnosis? So I already touched on this. You're going to be paying attention if she presents with pain or is it painless vaginal bleeding. This is painless vaginal bleeding, classical presentation of placenta previa. Painless, bright red bleeding with a soft uterus, placenta covering the os, placenta previa. Abruption is going to be painful. Vasa previa causes fetal distress, and the rupture causes hemodynamic instability. A 55-year-old woman taking tamoxifen for breast cancer surveillance reports new onset postmenopausal spotting. Transvaginal ultrasound shows a diffuse thickened endometrium. What is the most appropriate diagnostic step to evaluate for endometrial pathology? So is it A, hysteroscopy with a directed biopsy, repeat transvaginal ultrasound in 6 months, pap smear, or a CA-125 measurement? Well, she's going to need a hysteroscopy with direct biopsy. Tamoxifen increases the risk of endometrial hyperplasia and carcinoma. So they can also ask you a question, what are the side effects of tamoxifen? And that could be endometrial hyperplasia and increased risk of carcinoma. Hysteroscopy with a targeted biopsy is definitive for diagnosis. Waiting will increase the risk of missing the cancer. Pap smear does not reliably detect endometrial cancer, and CA-125 is non-specific and non-diagnostic for endometrial pathology. So giveaway, she has been using tamoxifen, she has new bleeding, so look directly at the lining with the biopsy. A 34-year-old woman in her third trimester presents with a sudden painless vaginal bleeding. Again, sudden painless vaginal bleeding. She has no abdominal pain and her uterus soft and non-tender. Fetal heart trace is reassuring. This is placenta previa. A 17-year-old girl presents with a primary amenorrhea. She has a normal breast development, minimal pubic hair, and a short vaginal canal with no palpable uterus. Karyotype is 46XY. What is the most likely diagnosis? Turner syndrome, androgen insensitivity syndrome, Mullerian agenesis, and hypothalamic amenorrhea. Well, this is androgen insensitivity syndrome. Correct answer is going to have your XY karyotype, normal breast, absent uterus, androgen receptor defect. Turner has a streak ovaries and no secondary sexual traits. Mullerian agenesis has normal pubic hair, and hypothalamic amenorrhea lacks the estrogen features. So in this case, you're going to see 46XY karyotype, short vaginal canal. That should make you think of androgen insufficiency syndrome. A 21-year-old woman presents with a cramping pelvic pain during menses. The pain improves with NSAIDs and OCPs. Pelvic exam is normal. What is the likely diagnosis? Primary dysmenorrhea, endometriosis, adenomyosis, PID. This is a primary dysmenorrhea. Normal exam with pain due to the prostaglandin excess. Endometriosis pain is chronic, not just menstrual. Adenomyosis causes enlarged uterus, and a PID has fever and discharge. So pain with normal exam, prostaglandins are to blame. A 52-year-old woman reports hot flashes, night sweats, and vaginal dryness. Her FSH and LH levels are elevated, and estradiol is low. What is the most likely diagnosis? Premature ovarian failure, menopause, hypothalamic amenorrhea, and hyperprolactinemia. Whenever you see increase in FSH and LH with a low estrogen, you should be thinking about menopause. Cessation of menses greater than 12 months with a high FSH and LH and a low estrogen. Premature failure occurs before the age of 40. Patient is 52. Hypothalamic causes low FSH, and hyperprolactinemia suppresses FSH and LH. Hot flashes plus high FSH should make you think of menopause. A 29-year-old woman reports severe mood swings, irritability, and hopelessness in a week before menses, resolving afterwards. These symptoms disrupt her work and relationships. What is the first line treatment? Oral contraceptives, SSRI, GnRH agonist, cognitive behavior therapy. She needs an SSRI. So she's dealing with the premenstrual dysmorphic disorder, which is severe form of PMS. Serotonergic therapy is the first line. OCPs can be adjuncts, GnRH reserved for refractory cases, and CBT is helpful but is not a primary treatment. A 22-year-old woman presents with a purulent cervical discharge and easily induced bleeding during the PEP collection. NAT is positive for Neisseria gonorrhea. What is the best treatment? Ceftriaxone, doxycycline, azithromycin only, metronidazole, or penicillin G? Well, this is a presentation of gonorrhea and chlamydia coverage, so she's going to need ceftriaxone and doxycycline. Azithromycin alone will miss the gonorrhea. Metronidazole is for trichomonas or BV, and penicillin treats the syphilis. So she presents with gonorrhea chlamydia presentation, and she needs ceftriaxone and doxycycline. A 27-year-old man presents with a painful genital ulcer with irregular borders and purulent base. Multiple tender inguinal lymph nodes are present. What organism is responsible? Haemophilus ducrei, Trypamona pallidum, chlamydia, or HSV? This is a classical presentation of the painful soft chancery with tender nodes. So this is a chanceroid, Haemophilus ducrei. Syphilis ulcer is painless. LGV causes lymphadenopathy, but not purulent ulcer, and HSV ulcers are vesicular. So HD, chanceroid. HD for Haemophilus ducrei makes you think of chanceroid, painful, soft, tender nodes. A 30-year-old man presents with a painless genital papule that resolved followed by painful inguinal buboes, I think you say buboes, weeks later. He is sexually active with multiple partners. What is the causative organism? Trypanoma pallidum, HD, chlamydia, HSV2. This is going to be chlamydia presentation. LGV, transient ulcer, and painful lymphadenopathy should make you think of chlamydia trichomonas presented as part of the symptoms of LGV. Syphilis has painful ulcers without lymphadenopathy. Ducrei causes painful ulcers, and HSV gives vesicular lesions. First quiet, then swollen, LGV, double token. So if patient has first quiet and then swollen lymph nodes, you should be thinking about LGV. A 32-year-old woman presents with a single painless ulcer on her labia and firm, non-tender lymphadenopathy. What is the best initial diagnostic test? VDRL, FTA, dark field microscopy, or NAT? So To diagnose syphilis, we're going to go with dark field microscopy and direct visualization of T. pallidum confirms early infection. VDRL may be negative early, FDA confirms but not initial, and NAT is used for chlamydia and gonorrhea. So for syphilis, think dark field microscopy. A 24-year-old woman presents to the emergency department with acute lower abdominal pain that begins suddenly during exercise. She reports mild nausea but no vomiting. Her last menstrual period was 2 weeks ago. She is not using contraception. On exam, there is tenderness over the right adnexa and an absent Doppler flow on ultrasound. Beta HCG is negative. What is the most likely diagnosis? Ectopic pregnancy, ovarian torsion, ruptured corpus luteum, PID. This is a classical presentation of ovarian torsion when there is a sudden pain with an adnexal mass and absent blood flow to confirm the torsion. Ectopic would have positive beta ACG. In her presentation, beta ACG was negative. Ruptured corpus luteum causes mild bleeding but preserves the blood flow. And PID causes gradual pain with fever and discharge. So sudden twist, silent flow, torsion seals the show. Sudden twist, silent flow, torsion steals the show. A 34-year-old woman presents with a thin, gray, fishy-smelling vaginal discharge. Microscopy shows clue cells. What is the treatment? Metronidazole, fluconazole, azithromycin, or doxycycline. Well, this is a classical presentation of BV with that great fishy-smelling vaginal discharge, which is caused by Gardnerella vaginalis and is treated with metronidazole. And if you remember, with metronidazole, they should not be consuming alcohol. Fluconazole for Candida and C&D, azithromycin and doxycycline are used for STIs. So fishy and gray, Metro saves the day. Fishy and gray, Metro saves the day. A 27-year-old woman reports intense itching and a thick white discharge. On exam, there is vulvar erythema and cottage cheese-like secretions. What is the treatment? Fluconazole, metronidazole, azithromycin, or doxycycline. She needs to be treated with fluconazole. So this is a classical presentation of Candida albicans. Antifungal therapy is needed, so we're going to go with fluconazole for that itchy, thick, white discharge. Metronidazole is for BV and trichomonas, and azithromycin and doxycycline are for STIs. Itchy and white, fluconazole is right. Itchy and white, fluconazole is right. A 60-year-old postmenopausal woman complains of vaginal dryness and dyspareunia. Exam shows pale, thin mucosa. What is the best treatment? Topical estrogen, lubricants only, oral progesterone, or oral antibiotics. Topical estrogen. So this is atrophic vaginitis, which we need to treat with a topical estrogen. Lubricants only is for symptomatic relief. Oral progesterone is not indicated, and for antibiotics, she has no infection. So thin and dry after 50, estrogen makes it nifty. Thin and dry after 50, estrogen makes it nifty. A 16-year-old girl presents with a primary amenorrhea. She has a normal breast development, but scent pubic hair and a blind vaginal pouch on exam. Karyotype reveals 46XY. What is the most likely diagnosis? Androgen insensibility syndrome is the correct answer. I totally messed this up. I apologize. So A was androgen insensibility syndrome, B is Turner, C is Mullerian agenesis, and D is hypothalamic amenorrhea. So with 46SY, you're going to think androgen sensitivity with female phenotype, scent pubic hair, and absent uterus. Turner is going to be 45X, Mullerian agenesis 46XX, and hypothalamic amenorrhea shows normal anatomy but low gonadotropins. Thank you guys so much for another video, and I will see you in a part 4 when we'll cover the last 30 questions. See you in the next one.